don't know if you're familiar with, but Dr. Jones's lab out in Reno, they just came up with a saliva methylation test. Are you familiar with that? And we were an early contributor to that. Now he's working on getting that CLIA approved, and he's looking for about 100 people. And the criteria for that is whether you have FSHD or not. It's not as important. But what is important is you've had a genetic test. So you may have somebody in the family, what's called a proband, presenting the most, and then you can begin to look at the family, because generally this is, as you know, autosomal. It comes down from generally one parent. The de novo is a relatively small percentage but it's mostly hereditary disease here. But since it presents so variable, as you know, Dr. Jones is all about the epigenetics. So, and that's sort of what attracted me to him, because it's like, well, why now are my legs failing when all of my 48 years they've been fine, even though I've been genetically, have that issue. So the methylation test that Dr. Jones is doing, and he may even actually be able to predict the deletion sequence at some point, as opposed to the Athena DNA, which could be a lot of money. Insurance companies aren't going to pay that. And the value of that study is, if the family's been genetically tested, like my family has been. I have it, my brother has it, it came down from my mother. My sister doesn't have it, my father doesn't have it. We've all been genetically tested with Athena, I think through Kennedy Krieger. And he likes that data. So if you have a family member, God forbid a son or a sibling or a cousin, it's good to look at that family to the extent that you can get a genetic test first for the purposes of Peter Jones's test, because then he can correlate his results to the DNA and see if there's a strong correlation between his prediction. And insofar as what you just said about, you're trying to predict the course of the disease, in my case, my allele deletion is somewhat attenuated. It's below 10, but it's not 3 either. And I'm in that, what I call that Goldilocks zone, where hypomethylation could play a key process of how this disease presents. And he just gave me my number. So I'm coming in at 23. So I think 25 and higher is potentially normal, but if I got that right, but I'm at 23. And it's only on that one side, right? So
yeah, you got it. It's a little hard with the methylation because there's a lot of different ways they measure it. And so for him, he's working on a diagnostic test, which will have a cutoff for whether you have it or not. But interpreting the actual amount is a little difficult because of the way it's measured, but it's possible. So there have been studies looking at that. I don't know if you're familiar. You can do can actually look in a really large group of people, and the number of those repeats in a rough way correlates to the methylation you see in the region.
Right, so the greater the deletion, the greater the hypomethylation that takes place.
That's right, exactly. Right. And so what you can do is you can, and they've been doing this to help identify genes that might be modifiers for FSHD, but you can say, well, we can predict what your methylation would be. It's not that exact, but we could say you have 9 repeats. We think your methylation should be in this zone.
Right.
And then you can measure it, and you can look at the difference between what's measured and what's predicted. And if it's large, then it's just what you said. You'd say, well, this is evidence that there might be some other factor that's affecting. Yeah.
Right. And when Peter just gave us that result about 2 days ago, it took about 5 days to get it. He says he can expedite it in 2 days. And the thing that's really cool about his test is once you give that saliva test, it's stabilized. He says it could last for 5 years. So unlike blood, you have to get it somewhere quickly. And it's very inexpensive. Send it to the postal. He could send these things out all over the world. And maybe in countries that are less developed, in Africa or some areas like that, and reach a bigger group. And one of the things we're trying to do is the incident rate, the prevalence rate used to be thought of as about 1 in 20,000. Pretty rare. But the recent study, I think, in the Dutch study or something like that, they took it to maybe as low as, or as high as 1 in 8,000. And I certainly believe it's probably more prevalent than that. And people are presenting, like my mother didn't start to present symptoms until her 80s.
Yeah.
And we actually believe, and this is a question I'd like to ask you to the extent you can, is she took she took a statin for lowering her cholesterol. And ever since she took that, she began to present, in my opinion, neuromuscular issues, which was diagnosed, or by doctors and said, well, what you have is polymyalgia. So she's been sitting on prednisone for 6 or 7 years. not a good situation. She's got tissue paper for skin.
Mm-hmm.
And interesting enough, Dr. Laura Ellman at University of Pennsylvania, who was the ACE-83 study, said, oh, you should never take a statin with a neuromuscular disorder or muscular dystrophy because it's toxic to the muscles. So, I think about stress factors potentially. What could, is there any direct relationship, correlation between taking a statin or any other potential drug that could have a bad interaction with FSH and actually make that condition worse? At any rate, getting back to Peter, his feeling was, based on the result of the study, if he didn't know anything more about me, he would have concluded that I would be a relatively mild presenter. So that is an interesting correlation.
He thought you were on the upper end of his, where his cutoff would be. But
Right, where I could be most responsive to treatment.
And, I don't know yet because we don't have that treatment. But I would certainly hope. I would hope that you would be responsive to the treatment. And I think I think that diagnostics, though, which is I think your main point here, is still a major issue for FSHD. The testing is still complicated. As you know, it's often a two-stage test where you look for the size of the deletion, then you have to look for methylation and/or second mutation. To simplify that would be a great benefit for the field. But I should also point out there are programs. This is for whoever may be watching here. If you join the U.S. Registry of FSHD Patients and Family Members, it's on the internet and it's housed at Rochester. There's a program going on now to get free genetic testing for people who have
that's
been
awesome.
tested. Yeah.
I think the muscular dystrophy through Dr. Ellman's office did pay for that test. And I don't know if you could, Riley, give us that or the URL for that.
Yeah,
what I can do is I can put that up on the video.
Give you the URL for that.
Great.
And the MDA. You used to be able to. The MDAs now you can't actually use your clinic money for direct patient care, but they do support a lot of important things. All those other people we have in our clinics, the physical therapists, the occupational therapists, but. I think what's happened in the world, if you look at some of the other dystrophies we see, like limb-girdle dystrophies, these free genetic testing programs have really done wonders for increasing the number of people who've been able to get genetic diagnoses. Unfortunately, FSH, because of the nature of it, has been much harder, and so we really haven't had those large free testing programs yet. But I think that, like I said, the registry's one, and I'm hoping, hopefully, Peter Jones' technique will be validated soon, because we need a cheap and an easy way to get people.
So what I think the key thing is to play off what Jeff was saying is the more when I first got diagnosed as a potential for FSH, just from my clinical presentation or my science, my initial feeling was I don't want to do the DNA test. There's no treatment. There's no cure. What's the point? But I thought about it for a good 6 months, and I decided to come back. And do it. And pretty much when I actually saw those children, it made such an impact on me that I stopped thinking about it from everything happening to me. What can I do for me? And I actually saw that you do these things for everybody else. I mean, that's, at least for me, that's what it works with. So even if I don't receive the benefit in this time frame in the next 5 or 10 years, it's from 2009, I think you indicated, right? This was the DUX4 mechanism, right? So just in 9 years, we go from what are the underlying pathological mechanisms to this complex combination of genetics and epigenetics. What are these processes? Very complicated. To now we think we know exactly what's going on with DUX4. Maybe not exactly how all the transcriptions go or some of these other combinations of epigenetics or other parts, but we're getting there. We have a target, which we believe if you eliminate DUX4, even if you knock it down sufficiently, you eliminate the toxicity regardless of what are those downstream processes. So that's a wonderful target. And how did that happen? By getting people tested and given the variability of the disease, your family may have it. Somebody's not even presenting. So getting that data set, I believe, in my heart, I believe that instinctively, or whatever the word is, that the prevalence is even higher. And the importance of that is the more the pharmaceuticals, at some point you're going to have pharmaceutical involvement. They obviously need to get a return on their investment dollars. And if it's 1 in 40,000 versus, let's say, 1 in 4,000, that's quite a big difference. And there's more people that could be treated. So that's the importance of, if you have a son, cousin, or a relative, or yourself for that matter, genetically confirmed to have FSH, we got to look at that overall family, and that would even help. So to the extent that I know Peter is asking, he would love to get 100 people for his methylation test, and he's working through that CLIA approval, I guess, in 2 months. So I think we've already got potentially 3 new candidates. I have a friend of ours who we came across on YouTube by the name of Russ Cleve. He tried some stem cell research in China for quite an expense, and now he's wheelchair bound. So within 2 years, he's gone from being not mobile and really confined to a wheelchair. So we made some videos. He's up in Portland, and his family was really ravaged by this disease. He lost a younger brother at a young age, more adolescent onset. He had like ALS symptoms. He lost his ability to breathe, unfortunately. So it worked. And that function, horrible. He's got like a sister. He's got another brother. His parents. So he's gonna and a grandson now. So you got potentially 3 generations of family to look at, and now he's going to get 7 members of his family that have been genetically, confirmed or clearly presenting to go to Dr. Jones' test. So between my family and that, just within a week, we've got 10 people. So we hope if you see these videos or you're in Facebook, please join. And we need that data. The quicker we can get these sampling groups, the better your data results are. It's going to help short circuit all of the effort that here Dr. Statland is working with all the others. So please participate.
Yeah, I think it's time to be involved.